want to start off by just kind of giving some really an update for background on what's going on right now and looking at some of these insurance policy recommendations to really kind of get an idea of how valid are they as far as the standards and how are our patients really being affected, because that's really the key, is really how are our patients being affected in their access to care with these insurance company standards. So this is a recent one by Aetna that just got passed in August of 2013. Aetna, as I'm sure you know, is a large commercial payer. They had just bought out Coventry, and when they brought out Coventry, they actually incorporated many of their policies selectively into their current policies for an update. And this one policy came out saying basically in cervical spinal fusions, spinal cages are no longer medically necessary for use. And we know that from a practice standpoint, surgeons doing anterior cervical decompressions and fusions will frequently use cages. You know, typically polyether ether ketone or PEEK cages or metallic cages, whatnot, but it's commonly used. So the whole idea is how did they also come across that this is medically unnecessary? And if you just look at this policy, you're like, wow, well maybe it is. You know, how are we gonna address this? When you look at the issues of how they came about through the Coventry policy, you realize that their conclusion was derived from the 2004 Cochrane Systematic Review, and specifically in that review, looked at a paper by Varouk in 2002 comparing Cloward versus carbon fiber cages for ACDF. And that's how they came out that at that time, cages versus graft versus ACDs or anterior cervical discectomies alone made no difference. The problem is that that paper had a lot of problems. Most of those patients, in fact, actually a high number of those patients, didn't fuse with pseudoarthrosis, so it didn't matter if you used bone graft or a cage, the patients didn't do well in the first place, so that's why when you say that it made no difference to use cages, it was tough to assess. The problem is that they also ignored the 2011 Cochrane review, which reviewed this again with a larger number of patients that actually showed equivalency of using non-cadaver cages to iliac crest autograft, our gold standard for fusions. And so if you looked at the Cochrane review, it actually demonstrated that autograft was actually associated with more complications than a cage and with equivalent efficacy. Based on complications, the authors from the Cochrane review actually considered that based on that evidence alone, it actually favored the use of cages over going to the iliac crest for your fusions. So it's one of these things where when you look at that, you're like, wow, all they had to do was just look at the updated literature versus selectively looking at older literature for their policies. And so we had to write a response that was being submitted that just really says, you know what, it's hard for us to imagine why you would reconcile the position that the cages were experimental investigational, especially when we know we have patients. For example, in Tennessee, we have a large, ethnic population with certain religious and cultural beliefs, whether you're a Jehovah's Witness that doesn't want to have blood products or your religion doesn't want you to have any cadaver products, for example, in the Southwest areas as well, or for patients who have really bad bone quality who would benefit from cages versus allograft or going to their hip to harvest autograft, for example, patients with parathyroid hormone deficiencies, renal osteodystrophy, et cetera, chronic steroid use. It's hard for us to imagine why we can't have access to cervical cages for these patients that would benefit from them as an effective option. So that's one issue. How about this? Aetna also has a policy looking at intraoperative or EMG monitoring, or electromyographic monitoring, saying that there's insufficient evidence to be used in spinal surgery. And so because it doesn't assess adequate nerve root decompression, detect nerve root irritation, et cetera. And when one of our members brought this up, and after their conversations with insurance company, they quoted AANS-CNS in our spine section for coming up with a position statement that justified their position on why they didn't need to use intraoperative monitoring, and that's kind of true. And so this is another issue, a different facet of using blanket statements, looking at healthcare policy and trying to use one comment out of context to support documentation or justification for monitoring. Because as a neurosurgeon, I know that my colleagues, for example, when we do a trans-psoas procedure or going through the plexus or doing a revision spine where you're trying to dissect out nerve roots or taking out a tumor, we know that monitoring, especially around the nerve roots, can be very important and very beneficial to our patients. So how is it that the spine section came out with a statement saying that it wasn't always needed? Well, let me kind of explain. So the spine section's position statement, which I'll go over, came about due to this publication in Neurology based on AAN in association with the American Clinical Neurophysiology Society. And they did an evidence-based guideline that was published in March 2012, which basically stated that intraoperative monitoring is effective and basically was able to predict an increased risk of adverse outcomes of paresis, paraplegia, quadriplegia, and spinal surgery. And they recommended that surgeons and members of the operative team should be alerted to the increased risk of these severe neurologic problems. It makes perfect sense. The problem was we had a group of legal people take it out of context, and we had members approach our organization saying, look, I'm getting sued now. I did a lumbar discectomy. The patient woke up with persistent radicular pain, and I'm getting sued because they're telling me I didn't monitor that patient. I did a single level lumbar interbody fusion, right, and the patient had an adverse event. And I'm getting sued now because I didn't monitor that patient based on these 2012 guidelines. So they petitioned through the Council of State Neurosurgical Societies that went through the AANS and CNS, that then came requesting the joint spine section to come up with a position statement so that our members didn't have to be at risk for not monitoring for lumbar discectomy. How many people think that doing intraoperative monitoring for a lumbar discectomy is beneficial? Most people don't do it. So we came up with a statement that says intraoperative neurophysical monitoring may assist. So even though we said that the routine use is neither warranted nor recommended, meaning that if you don't want to do it for a single level lumbar fusion, you really don't have to do it, and in fact, you shouldn't be forced to do it. We also put in there that intraoperative physiologic monitoring really is useful in areas of high risk, which is deformity, doing a trans-psoas approach, gross instability, navigation around the peripheral nerves, etc. But this is an example of how people will take some statements out of context and use this as a blanket statement saying, oh no, see, even neurosurgery agrees that we shouldn't monitor. That's not quite true. We think that there's good indications, but we also don't want to protect our members from inadvertent risk from a legal standpoint just because they don't think it's a utility for their patients. Just in the sake of time, I won't go over these things about the lumbar fusion guidelines for your Washington State Work Comp, but I do want to highlight, for example, your Washington State Healthcare Authority. Our organizations came up, if you recall, earlier this year to help defend this issue of cervical spine fusion for degenerative disc disease. If you remember, this assessment by Washington State HCA and with their health technology assessment basically was making a comment that, anterior cervical fusions or cervical fusions for degenerative disc disease, we're going to deny them because they had no benefit compared to physical therapy or non-surgical treatments overall across the board. And so from a society standpoint, we got notified by the Washington State Neurosurgical Association. We're like, wow, that's not right. We know that cervical spinal surgery and fusions are certainly beneficial in patients that would benefit from it and need it overall. And their draft evidence report, which was commissioned through a third-party outcomes based out of Massachusetts, I recall, came up, and this is just, they had a number of points, but this is just one of them, saying in cost comparison, the value that Carlo was talking about, comparing spinal fusions to other treatments. For example, if you look at the incremental cost per quality, compared to physical therapy, spinal fusions would be $136 million more for the incremental benefit compared to physical therapy. But then if you look at laminar frame-otomy, how is fusions less than a posterior laminar frame-otomy? That made no sense to us. You have no implants, you have nothing for a laminar frame-otomy. Your anterior cervical discectomies alone versus fusion, the ICER score was $1.6 million. Epidural steroid injections, $170,000. So when you look at these numbers and they just hand you this grid, most of the time you look at that and you're like, wow, you kind of take the data at face value. You don't disagree with it, I guess. But then, you're like, well, how are we going to argue against this? Well, you can't accept all data given to you as having the same fidelity as not. So, for example, just looking at this grid, how did they come up with this? It was a really flawed model. So when we analyzed this whole model system they used was based on a Markov decision model. So with a lot of upstream errors. The problem is garbage in, garbage out, right? For any modeling system, whether it's a finite element analysis in biomechanics or a analytical decision model in healthcare economics. And the problem is that their model for the benefits of surgery was based on the Kandanka 2002 paper on myelopathy, which reported function, not pain. So not only did they have the wrong disease state, right, comparing cervical myelopathy to cervical radiculopathy, which as clinicians we know doesn't really match up. Yes, they're both neurocompression, but two different disease states and treatment processes. But they actually had the wrong endpoints within their model. The other problem with this is that the assignment of utility for surgery was severely flawed. So Carlo talked about the EQ-5D or the Urquhart 5D for the pretreatment, and what they did was they compared surgical outcomes from large population studies, for example, by Sullivan et al. The problem with these large population studies is that they're not specific for surgical patients, right? These could be patients who come into their doctor with a week of neck strain, who wake up with a crick in their neck and getting some ibuprofen, who then improve over time. So the problem is that if you compare, so how many people will take a patient to surgery after 1 week of neck pain with nothing else, no findings? Nobody. So the most appropriate assessment of surgical patients are actually patients who fail conservative treatment. Okay, the patients that fail conservative treatment, after they do that, you randomize them into surgery or send them to more conservative treatment. That's the patient group that surgeons are culling from as far as the patients that we treat. No one treats 1 week neck strain or acute neck pain or waking up with a crick in your neck with surgery. So comparing surgical outcomes with people that would benefit from ibuprofen and going home and sleeping it off, it really makes no sense. And there was a number of other points related to their whole decision model, which really biased the data against surgery. So we came up with a number of presenting organizations. I actually flew up to Seattle and represented the whole list of organizations that you see here, and we're able to at least get coverage restored back to appropriate criteria, that is taking care of patients, with myelopathy and radiculopathy, with deformities, et cetera. Certainly none of us would do cervical spinal fusion, someone who just pure neck pain and no objective findings, no radiographic diagnosis. I mean, that's silly for anybody, right? So if you want to not cover that, we agree with you, I guess is the bottom line. So one of the problems with this is how to assess all these policies. One of the tools that we use is a modification of the appraisal of the guidelines and research evaluations called the Gris Instrument, which is actually used to assess clinical practice guidelines based on the evidence-based rigors of development and a critical appraisal. We have to modify it because some of the things related to clinical practice guidelines and their publications does not apply to healthcare policy, because things like editorial independence, if you're Aetna with your own healthcare policy, there is no editorial independence. You work for Aetna. That's just the way it is. So we used a modified Gris tool to look at policies with the whole understanding that payer policies actually act just like clinical practice guidelines. They actually drive how your patients get care, what type of care they can have access to, et cetera. And that patients, along with clinicians and policymakers, really benefit from methodologically sound evaluation of the medical literature for the best practice with respect to benefits, costs, and harms. And that we agree that the highest quality evidence should be used by everybody. I don't care if you're a clinician, guideline writer, policy writer, you really should be using the highest quality literature, but there's only a finite pool of literature, right? And it should be the same group of literature that we do, and it should be transparent, meaning that I shouldn't have to guess what you're thinking, like what we had to do with some of these policies that I printed out, where it required a lot of time and effort to research and figure out what the heck, how did they come up with their data in the first place for us to even comment on to begin with. And that we think that a guideline, policy are the same. Now, there is a difference between how they derive it versus the state of the literature, and that's another comment to point out. That a guideline can be rigorously developed and well executed and have high quality, but based on poor availability of clinical data. On the other hand, you can have great clinical data in the literature, but really a poorly developed guideline. And those two things need to be taken into account because they will both affect how we derive things. So when we compare clinical policies to guidelines, and this is a paper that we published back in 2010, I believe, looking at clinical policies comparing to fusion guidelines, we noted a number of things at that time, including that they all included some sort of randomized trials, other things. Certain policies relied on primary studies, but other policies like Aetna and Cigna looked at HTA reports, or more what we call gray literature, because it's already been taken, it's already been processed with certain biases built into it, and it's no longer considered an unbiased report. And the problem that we saw was that there was no clear pattern in the agreement of the quality of development based on our modified Gris tool. I think this chart says it all. on the y-axis is just a list of studies. There's only a finite number of studies that have done, right? And you can have the level of evidence rated, right? There's only so many randomized controlled trials, cohort analysis, et cetera. If you look at the guidelines and the policies on the x-axis across the board, you notice that, boy, depending on which data they select out, seems to drive their stance on that position. So for example, if they pick mostly non-surgical studies or non-efficacy studies in surgery, they would come up with their policy saying this isn't indicated versus those that looked at the whole spectrum of data. And so just using the agree tool and just putting this across, you notice that Aetna, Cigna policies at that time actually had some of the worst things, right? If you look at the evidence base, did they show that they did a systematic method for evidence search to look at all the data? No. Did they include and exclude the data and it was clearly described so we know how they were not biasing the results? No. Did they do critical appraisal of individual studies or the overall quality of the evidence? No. Now the benefit you have is in Washington State, you have companies like Spectrum, which the Washington State HTA is using for the carotid stenting, which actually does do all of this. And so for that, it actually makes us feel better that you have to have some sound science behind the statements that are coming out from that. So in conclusion, what we found out was medical payer policies based on primary studies have a higher quality than those relying on gray literature, that is summary reports. So it's almost like your kid at school who says, you know what, I don't need to read the book, Mom and Dad, I just want to go through the cliff notes because that's all it takes, right? I get the highlights. But you know that if your kid does that, he's going to misinterpret a lot of the things within that book. But that's what's happening with these reviews. And that the medical payer policies that reviewed are really of poor to moderate quality, and we really need to make a concerted effort to hold the payer policies to the same standards as we hold guidelines because they really function in the same fashion, driving the direction of patient care in our field. Thank you very much. Healthcare providers are like kids between two fighting divorced parents, hospitals and insurance providers. And I'm glad that Carlos finally put me to the task of explaining what I mean by that, because what you'll see is that their business model of both the insurance company and the hospital are really different. And they're actually on diametrically opposed sides, and why we many times feel like we're just getting tugged in all sorts of different directions. No new disclosures since the last time I gave them. So Warren Buffett says the first rule of investing is don't lose money, and the second rule is don't forget rule number one. And you have to remember that healthcare is a business. For some of us, it's a calling, it's what we want to do, but for others, it's a career, it's a job, it's things that you do, and in order to stay in business, you have to have a profit, right? No margin, no mission is the current theme of the day. From a hospital standpoint, we're part of their business. And in neurosurgery and orthopedics, we're actually one of the largest contributors to their bottom line. So the hospital's view of service lines for spine is that it's a high revenue, high cost. It's a variable volume, but it's not really capital intensive because much of the high cost has to do with implants, things that don't require capital outlay to bring it in. Neurosurgery, on the other hand, is medium revenue, medium cost, but it does require a lot of capital investment. So for example, if you want to recruit an endovascular neurosurgeon, you better build an endovascular suite, which will cost you a few $1 million to set up. And then even after that is a variable volume based on the number of stroke patients and et cetera that you get in. So that's how some of our service lines are viewed. But it's more than the direct costs and benefits that hospitals see us on. Some of them should also be the non-financial. So for example, to hold a level 1 trauma surgery center, you need neurosurgeons. And so that's why many facilities for both level 1 and level 2 trauma centers will start paying call stipends because otherwise they just can't recruit and retain neurosurgeons to actually stay on staff to cover those patients that they need, especially in states with certificate of needs or CON states that are obligated by their certificate to provide those services. Same thing with stroke programs. That's why you have to have an interventionalist, a neurologist, et cetera, and you can kind of get the whole gist of that. The other thing is that there are areas, what we call centers of excellence, that are used for marketing and signature programs that help hospitals compete with one another. Those are also those indirect needs that's important for you to understand are there so that when you negotiate for your position, you're able to then better see what your strengths are as you move forward on that. The hospitals look at admission severity groups because hospitals are really paid by diagnosis-related groups, and these are what many of you see as the DRG payments. The outpatients are a little different. For example, outpatients, ambulatory surgery center payments are, for example, like anterior cervical fusions or arthroplasty, are paid at a different way, so that instead of combining all together, you have to have what's called a pass-through payment on top of that. But for most of the time, inpatient payments, and this is just a 2011 chart that I cut and paste to show you the Medicare reimbursement. So hospitals, when you see a patient with no comorbidities, with major comorbidities, their payment rates are different. And that's what they get is one lump sum to provide it. Just like you will get a 90-day global period to provide all that E&M visits for your patients that you may or may not get paid for. So that if you're 90-day global, you only see the patient twice, you've made it a lot better than the person who saw him 6 times. So that's one of the components the hospitals look at as well, which is why length of stay and all those issues become important, because you're already getting paid this lump sum. And so the less resources you use to provide that care during that lump sum period, the more margin you will gain. The payment formula is based on a number of things, including a lot of hospital weights. For example, things like transfer patients versus non-transfer patients. And transfer patients actually increase the per diem amount and actually add to the DRG weight, which is why a lot of facilities have transfer centers. I don't know about your institution, but that's one of the reasons why many institutions set up call centers, because we want those patients. And so it only makes sense, right? You want to put in resources and start programs that bring in the best bang for the buck overall. And in spine surgery, we actually have a larger proportion of these patients that fall within the higher severity groups. So for example, comparing lumbar fusions to knee and hip replacements and shoulder replacements, you notice that the proportion of those in poor health are a higher percentage for those undergoing spinal surgery than the other orthopedic type procedures that I mentioned before. The same thing with the average length of stay. With the lumbar fusion, average length of stay is 4.07 days, which is higher. Now, what this also means is that typically we are underpaid for our lumbar fusions. So CPT code 22612 only averages out 4 days for length of stay. So in the Medicare population, they're only paying us for 4 days for the length of stay, but 4.07 means that most patients actually stay longer. So by definition, we actually are underpaid for lumbar surgeries, which I know most of you in the audience like, really? I always thought it was the other way around, because that's what we're always being told, right? When hospitals look at this data, they actually do a surgeon analysis, and this is just what we call a scatter plot of the average variable cost. So for a single MSDRG of what we know we're going to get paid at the hospital, we can look at your average variable cost, so that surgeons that use a lot of new technologies and new expensive implants, you want to do anterior corpectomies and cages and plates and dynamic plating versus just pedicle screws in the back. You can look at that, and then they also grid it out by length of stay, so that, for example, those in this bottom left-hand corner are super cost-effective. Those up towards this corner in the top right are really kind of expensive, and what they'll do is they'll throw a thresholding line through here so that everybody below this graph is considered will add contribution to the bottom line. Everybody above that line actually is a loss leader. The surgeon cost buckets can be broken down, and they'll compare you to the other surgeons as well, looking at all these costs, pharmacy costs, radiology costs, et cetera. All these cost buckets are something that's used to analyze what the margin is going to be off of you as a physician and surgeon. Now, the only thing about these cost buckets is that not every one of them is equal. Some of them are pure loss leaders. So, for example, if you use central supply costs, if you're the guy that tends to always want an aqua mantis for all your cases, or those disposable bipolar tips, you're going to cost a lot more because those things aren't recoverable. On the other hand, if you're someone who orders pharmacy equipment or things that there's a separate cost structure to, or reimbursement structure to, i.e. radiology, et cetera, then those things are recoverable, and so you'll want to look at the cost buckets different and how you contribute to the bottom line. All of you are then going to be benchmarked. So for example, looking at the various MSDRGs and your volume, not in length of stay, not only compared to the length of stay of what you do, but you compare it to equivalent institutions. So for example, University of Washington will probably be compared to other academic centers of the same population size within the city to get a benchmark of what types of patients you take care of in your draw area. If you look at this case where even though the average severity score was higher in this program compared to the comparable programs overall with equivalent age, one of the things you notice is that the length of stay was 6.9 compared to 2.2. And so this will then start driving people to say, what's the difference between the surgeons that we have at our program that has an average length of stay of almost 7 days compared to other academic centers or other private practice centers where their length of stay is a third of that. And so that's going to start driving some of these decision models overall. They also then look at your payer analysis, because bottom line is that hospitals are dependent on you as a physician in your clinic to select out the patients, and you actually have all the decision-making capacity and related to this. If you see a patient with Blue Cross Blue Shield and you bring them to surgery, the hospital benefits from that. If you see a patient on Medicaid and you bring them to surgery, the hospital sees Medicaid payments. So that's one of the things where the hospitals really are trying to bring in practices so that they can have some influence into this, because otherwise they're at your mercy on your decisions in your clinic overall. The payer analysis makes a huge difference because the payments, whether Medicare, Medicaid, commercial, private insurance, you can see the difference in the payment structure overall. And these payment structures are huge, much, much bigger than what you get paid as a physician. You may sit there and worry about 100% Medicare versus 130% Medicare. That's great, but that pales in comparison to facility fees, which will be significantly higher than what you're ever going to get paid, and makes a much more impact to the overall cost of the patient. These allocations are also dependent on your decisions in the operating room. So for example, this is a bad scenario if your implant costs are starting to creep up to 55% of your variable cost allocation compared to the nursing salaries, ancillary costs, or anesthesia recovery costs. You start realizing this is when hospitals start coming to you and saying, hey, let's review our implant contracts again, and let's talk about what type of cases you do, because you're killing us. You know, we can't seem to meet our profit margin when we're paying out thousands of dollars in implant costs based on our DRG payment. Every one of these surgeons had a different company that they like to use. Each one of these companies had a different contract with the hospital for supply chain costs. That's why you range from a surgeon who costs them $4,000 to a surgeon that costs them almost double that. And so the question is, where are you going to fall within a line? And that's why it's important as physicians and surgeons to know what goes into this, because if you're out here, you're going to be a loss leader, and you may not be as valuable as you think you are compared to the guy that's only using the cheaper implants for 4 pedicle screws and 2 rods. Same thing with bone grafts, depending on your choice of bone graft. For a single DRG, for the same types of cases, your choice of using commercial bone morphogenic protein or demineralized bone matrix versus taking a femoral head, a fresh frozen femoral head, and crushing it up yourself to get all your allograft will vary your cost significantly, and again, add to the costs of your case for the hospital. At the end of the day, it's all about contribution. And so this is an example of a group that started having a significantly higher payments. They started doing a lot more deformity surgeries. And so for them, they're like, look, we're charging a ton more. We're getting paid a ton more. But guess what? It costs a ton more. And so the bottom line to the hospital actually was going down over time. At the end of the day, hospitals benefit from the more we do. The average revenue that a neurosurgeon will bring to an institution is $2.8 million. So that's why, if you think about it, why is it that hospitals have no problems paying out hundreds of thousands of dollars to help recruit people? Why do you think they want to send signing bonuses, guaranteed payments to bring in new surgeons to come in? Do you really think that we're that smart and good looking that they'll pay us hundreds of thousands of dollars just because we're the good people and we've trained hard? No. They don't pay us because we deserve it. They pay us because we bring in a lot more money than they're paying us back. So hospitals, on one hand, really want us to work hard. Insurance companies, they don't. And so that's the problem. I call this the accountable cost ring, and patients or purchasers, where all the dollars come from in the first place, are at the center. But hospitals, physicians, and the payers are like a triumvirate, where we're this triangle floating above the initial ring of the patients and purchasers, all on equal footing. So the hospitals benefit from getting us to do more. Payers benefit from getting us to do less. And so what does it mean? So what is our cost and what is our worth to the insurance company? Well, you have to remember, insurance companies are for-profit centers for the most part, and they make a lot of profits. This is all from, I just cut and paste this out of Yahoo, Cigna, $11.2 billion in gross profit in 2012. Aetna, $10.8 billion in gross profit. So certainly when you look at the healthcare reform and issues related to that, it all has to do with insurance reform and how the money's floated around. But no one's going broke anytime soon, as you can see. But how do they get their profit? And what is our worth? Do we contribute to the bottom line? So I'm going to start talking just a specific example of WellPoint. WellPoint was a merger of Blue Cross Blue Shield Indiana and California, which both of them were initially nonprofits, but when they came together, they actually formed one of the largest commercial insurance payers. As with any commercial payer and anybody with stocks, right, they have to file income statements. Part of it's called a 10K, which is part of their annual report that they have to file every year with the SEC. You can look at the 10K because it actually includes a lot of the information related to business risks, executive compensation, et cetera, in more detail. I won't belabor it, but I do want to point out that you can actually go and look at their annual report, just march through this. All of this data has to be audited, obviously, right? That's the whole point of the SEC rules, so that we can go and be fairly assured that these are fairly correct numbers. And you can see that, that the numbers are compared to the previous years as well. So WellPoint in 2012, the total revenue was $61.7 billion, and that's a lot of money. Well, where does all that revenue come from? Majority of it comes from premiums, what members pay. And so $56.5 billion came from premium revenues. $3.9 billion came from administrating. These are self-insured employers. For example, Vanderbilt self-insured, and even though we go through Aetna, all they do is process our claims, and they don't do anything else besides that. So they don't take any of the risks. The hospital, the employer takes all the risks of these self-insured areas. But if you notice, physicians aren't up there as far as what we bring into the insurance companies. They also get a lot of revenue from float money, and in 2012 it was $297 million. Float money is premium payments that are paid by the members before they pay it out in claims outlays. These are a group of money that during areas of high interest rates is a huge source of revenue. Right now we have almost 0% short-term interest rates, right? You see in your money market account, you're getting paid a fraction of a percent right now, right? But remember 10, 15 years ago, when it was 5-7%, you can get a CD for 8% interest. Wasn't that great? They thought so too, and that's why I had these accusations of claims processes. Even though this is a trivial amount, it's still almost $300 million, and we're now starting to see it from the front end as well, meaning that you ever thought, is there a benefit from them going to a third-party contractor saying, you know what, we went through a third-party contractor to pre-approve your surgeries, and now it's going to take us an extra 5 to 10 working days to get back to you to pre-approve your surgery. Well, that's 2 weeks of float money that now is going to be sitting there gaining interest. As you notice, that's all the revenue that they get in. None of this has to do with physicians, nurses, healthcare providers in general. So when you look at their gross profit about the revenues are really, or gross profits, really what they brought in revenues minus their expenses. And so in 2012, they made $14.5 billion, $2.8 billion was their total revenue above and beyond what they had to spend in expenses. One of their largest expenses is going to be what's called the SGA expenses, selling, general, and administrative, and that's the line that you'll see on their 10K form. In 2012, it's $8.7 billion, and typically they keep it around 14 to 15% of their total revenue. And without getting into more details, there's ways that you can account for various cost structures to keep these numbers looking roughly the same. What's a spine surgeon worth to the hospital or to the insurance company? Not much. We fall in this bucket. The health benefit ratio. It used to be called the medical loss ratio by the actuaries, but it didn't sound good, so they started changing the name to HBR. So this is it. In 2012, they paid out $48.2 billion. This is what they pay, this is what they quote unquote lose to doctors and hospitals, right? So the money that they get is already from the premiums. And so we're a cost center. And so the more we do, the more we take care of patients, the more they have to pay out on that. Typically, they keep it around 85%. The reason I was saying about the whole Hollywood accounting thing is that it seems like this is fair. 85% of every dollar goes back to pay for actual health care. The problem is that the definition of what is actual health care varies. And so some of the things that we would consider administrative costs, others may consider part of actually providing health care and goes into that, which is why the Accountable Care Act tried to hold this number to 85% for small groups, 80% for large groups. The problem is insurance companies are like, we don't know if we can keep up with that, especially if you're going to hold us to different standards of what we consider healthcare benefits to our members and actually call that money that we pay to physicians overall. So that would make sense why insurance companies seem to target us, because we're down here. Both hospitals and insurance companies target physicians Because even though physicians represent less than 5% of the healthcare dollar, we're the first step of all the healthcare dollars, right? So for example, your nurses aren't going to get paid in your hospital unless you decide to admit a patient there, right? The hospital CEO isn't going to get paid unless you decide to use that hospital. The implant manufacturer is not going to get paid unless you choose that implant, right? The rehab center, all the durable medical equipment manufacturers are not going to get paid unless you decide to do a deformity surgery and have the patient need all of these services after all. So it's called nipping it in the bud. If you can affect the first line, the first choice, the physician choice, you can actually change all the downstream effects by making that choice. So for example, this is a slide I got from Clarence Rotwidge when he's talking about building practices where most people don't care about the $282 that the surgeon sees the charges for a clinic visit and order x-rays. They care about the $7,300 in injections, all the downstream effect of the EMG CT scans. If you can nip this in the bud, you will. That's the reason why you have to get pre-certifications for CTs. You have to get pre-certifications for injections, but you don't get pre-certifications for E&M because it's pennies on a dollar compared to the overall cost in general. There's a high return of investment for the reimbursement for policy changes for lumbar fusion. And so for every one of these restrictive policies, there's a dollar value that comes back as far as what they gain overall. And that's why there's many, many articles and papers written on this. For example, Wall Street Journal in 2011, Dr. Deo pointed out that the average costs were $80,000 for fusions versus $23,000 for simpler surgery. You know, this was when he was criticizing surgeons for doing more complex spinal fusions over simple decompressions, and with the gist that there are prominent surgeons who have strong financial connections to device manufacturers doing this. Wow. Unfortunately, I think of this and go, holy cow, what a crock. Because if you think about it, surgeons aren't paid this dollars, right? These are all hospital and downstream effect payments. These have nothing to do with the surgeon's bottom line. So the hospital, the insurance companies don't care about paying a surgeon $5,000 for their fusion. They care about the $80,000 in associated costs related to that. They don't care much about your $1,000 for your lumbar laminectomy. It's going to be your $23,000 for the associated costs of care for your facility fees, et cetera. If you look at these values, you can understand what's the return on investment. As an insurance company, if I deny 15 spinal surgeries, if I deny 15 spinal fusions with this cost, I've already made a profit of $1 million. If I deny your fusions and make you do laminectomies, all I got to do is 25 times in a year, and I've already made $1 million in profit, meaning because I don't have to pay you that extra $1 million. So that's the benefit of the worth of a spinal surgeon, is actually getting us to not do things that are expensive and to keep us in doing simpler E&M visits and hopefully not more than that overall. But again, because the benefits of these two sides have nothing to do with the individual surgeon, I always find it a little bit insulting when they insinuate that we do these things purely based on personal financial gain, when as physicians, we're not the ones gaining from it for the most part. So why do they even care about what we do, and why do they even want us around if we're such a pain in the butt to them? Well, because of this. So out of their membership, there are 35.7 medical members, 60 million individuals through their subsidiaries. You have to remember, we are their product, okay? And health insurance is not like any other insurance where access to care is the product. We are their product. So it's almost like if State Farm car insurance says, you know what, we'll give you car insurance, but you can only drive a Ford or you can only drive a Nissan. How many people would buy that insurance versus buying insurance that lets you drive whatever you want? The dollars don't go directly to the beneficiary that's buying the insurance. What they're selling us is access to care. That's their conflict. They're selling us access to care, but they make their profit on limiting access to care. Reimbursement and payment to physicians to change behavior is really effective. That's been done ever since the Bain Report in 1959, when there was a misdistribution of physicians after World War II. Health Education Facilities Act in 1963, where we had a shortage of primary care physicians. Emergency Health Personnel Act, where we had underserved communities, especially in some of our American Indian areas, where we had to do that. Guess what? If you pay people more, they tend to want to take that job more, right? And it just seems to make sense. And if you pay them less, they tend to gravitate away from that job, right? So all of you in this room, I can say if I cut your salary in half, there's a chance you'll start looking for a job elsewhere if that happens. And so because of that, we're caught in this tug of war between, again, our insurance companies on one side trying to limit what we do, telling us that they're not going to pay us, to physician bonuses from the hospital side that says, you know what, we're going to pay you an RVU-based unit. You work more, I pay you more. This whole issue of national health care crisis is not new. Okay, ever since the 1960s when Medicare and Medicaid began, we've had a crisis. For those of you that remember historically in the 1970s with the Nixon's wage and price control, that was the whole point of price control. Stuart Altman, who I borrowed this slide from, was Nixon's healthcare economist. Used to tell stories about how he got yelled at by the pediatricians, telling him that he's decimating medicine by restricting people's access to care and when physicians get paid. It was so unpopular, it went away until, guess what? The whole Clinton era, but now we have HMOs, managed care organizations. Same thing, but they restricted access to care by restricting who you got to see. People were unhappy, which is why Hillary Care went away. So that's why it started skyrocketing again, and now we're going through the same cycle again. The problem is that they haven't affected the overall cost, and that's something I'll talk about in my next set of talks. But the bottom line is this is new. It's important, hugely important, for us as physicians, nurses, therapists, healthcare providers to start understanding this more, because at the end of the day, it's up to us to determine that our patients have access to the most appropriate care. Thank you very much.